What if everything you thought you knew about health was wrong? Today, we're busting medical myths with special guest Rita Rogers. From the hidden dangers of fluoroquinolone antibiotics to the shocking truths about vitamin D deficiency. We're diving into the number one thing she had to unlearn, and trust us, it's a game changer. Could mainstream medicine be leading you astray? Stay tuned because you need to hear this one.
The Discovery Doc Podcast, where your journey to empowered, non-toxic living begins. Join me, Dr. CeCe, a doctor of nursing practice, self-proclaimed toxin tamer, and mama of four, alongside
me, Anna Kate, your medical mystery overachiever. Together, we'll uncover the latest in functional medicine, debunk health myths, tame toxins, and provide practical tips for thriving in a modern world.
Get ready to take control of your health with expert insights, raw stories, and actionable wellness strategies designed to help you and your family lead vibrant, toxin-free lives. Let's discover together.
Welcome back to the Discovery Doc Podcast. This month, we are here with Rita Rogers from Boom Clap Podcast. Okay, that song plays in my head.
Every time.
Your head, the Boom Clap. Every single time that you hear this name and you go listen to this podcast, totally should. So this is where our 80s, 90s, early 2000 brain.
I was going to say, I'm not an 80s girl.
You are not.
I'm a 90s
You're
girl.
a 90s baby.
But thank you.
Okay, I just told him.
Rita is here with us, guys. And Rita was a CVICU nurse turned homeschooling mama who is passionate just about uncovering and revealing the truth as relates to all things healthcare. So we are so excited to get to know you and to have our community get to know you, Rita. Thank you so much for joining us today. Can you start just by telling us what your background is, what kind of led you to nursing in the first place, and ultimately what led you away from it?
Yeah, thank you guys so much for having me. I was so excited to be asked. It's been a while since I've been on someone else's podcast, and honestly, it's so good because being asked questions from someone else gets your mind thinking in a different way. And I really appreciate that because I'm just naturally curious and inquisitive. And I don't know, it leads me to think in a different way. So thank you so much. But yeah, about me, I'm a mom to 3 kiddos. I've got a 14-year-old, almost 11-year-old, and almost 2-year-old. 2 girls and a boy. We live on a farm in central Illinois, and I worked as a CVICU nurse, as you said, for 15 and a half years in a level 1 trauma center, teaching hospital, like running ECMO, being in charge, all of those things. And I would say what led me away from nursing, there was a bit of a lead away prior to me actually leaving the bedside. I would think, I really want to be home with my kids. I'm going to quit my job because it was just stressful. I didn't feel fulfilled. I didn't like everything we were doing. The care was really declining. Our surgeons at the time were not very good. And I was like, I just don't want to be a part of this. But then something would happen. And there was probably 4 or 5 other nurses I worked with that were the same way. Something would happen that day where a patient literally probably would have died if I hadn't been there. And I'm not saying that to toot my own horn. It was like there was an experienced nurse on shift, a lot of inexperience, and you need somebody that really knows what to do in those situations when a surgeon or somebody with higher level isn't present. And we're kind of losing that experience at the bedside. And so something would happen and reel you back in and be like, I really need to stay in this position. But then as 2020 hit and 2021 is when ultimately I left the bedside, I didn't get the COVID vaccine. I had been speaking out online a lot about what we were seeing. We were having patients come in with shortness of breath, having an obvious heart attack, and not getting care for 24 to 48 hours because the testing was taking that long. And the cardiologists in cath lab were wanting a negative COVID test before they would even touch a patient. So you're having patients roll in to cath lab with extreme, heart damage, coming back up with a balloon pump and needing an emergent open heart surgery because they didn't get care they needed because people were scared of COVID. So speaking out on that, speaking out about the fact that I already have underlying inflammatory issues. I'm not going to test that with getting a COVID vaccine that I know is going to increase the inflammatory cascade. And my hospital wasn't happy about that. I was running bedside ECMO. They had somebody lined up to take my place that day, came up and told me, if you don't put on an N95 mask and wear it all day long, which is unsafe. I was pregnant at the time. You can't work here anymore. And so ended up leaving that day in limbo, not knowing what was going to happen because they didn't really lose my job at that point. I was sent home with kind of like, we'll see what we're going to do here, but you're not welcome to work if you're not wearing an N95 all day. That was in August. September, at 20 weeks pregnant, I lost my baby. And a few weeks later, HR called me. I had worked with these people for 15 years. Nobody would speak to me that actually worked with me. They had the VP of HR dealing with me, called me and told me I was resigning. Wouldn't even fire me because I had such a good track record with the hospital and good reviews. They wouldn't even fire me. They told me I was resigning. Click, hung up the phone. And that's it. I still have my badge. I've never signed a piece of paper. Nothing.
What?
Yeah. They just involuntary resigned me.
What?
Yeah.
I didn't know that was possible.
I mean, highly illegal. Like that.
It's illegal. Yeah. I talked to a lawyer and it's illegal. But he said basically in Champaign County, it's worse than trying a case in Chicago. So unless I can get somebody to tag on with a lawsuit in a more conservative county, he said basically there's no case to be won and it's a waste of time. And also I was going through all the emotional trauma of losing a baby at 20 weeks. So I didn't even think to file with EEOC or anything. So I don't really have a suit at this point, but I don't want money. I just want people to know what happened is wrong, you know?
The integrity is what we're after, not
I'm so sorry. What a time for you to go through that loss and then to be, I mean, that is your second like home. You've been with someone for 15 years and dedicated your career and your energy and your time on a floor that is very intensive to just be stripped away from you like that.
Yeah. I'm a pretty strong person. And so sometimes I told my co-host Cecily this, and actually Alexandra and I talked about this that you just had on recently in an episode we did with her. And just the fact that like sometimes you think back on things, you're like, it wasn't that big of a deal, you know, because I don't know. I always feel like making things a big deal about myself is like somehow wrong. And I'm like, it wasn't that bad. And then I look back and I'm like, it was really bad.
No,
like, it was really bad.
Yeah.
It was really bad. So
absolutely.
Anyway.
Did that, how in terms of kind of the nursing, how did that make you possibly kind of lose respect for I don't just nursing in general? Was that really tough?
I had already lost respect. Like the respect wasn't lost because of that incident. It was only confirmed. The loss of respect was confirmed, I would say. But I had already lost respect because it had changed so much over the years. When I started nursing in 2006 at the bedside, I mean, it wasn't perfect. Certainly there were issues, but when a surgeon rounded on a patient, you got up and went in that room. You talked to them about the plan of care. There was a clear plan of care. The surgeon was very involved. They cared about the outcomes of their patients. When I ended nursing, people weren't using their stethoscopes to go in and listen to their patient's heart and lungs anymore. They weren't getting up when the surgeon rounded. If the surgeon rounded, often the surgeon was not even rounding at 6 o'clock in the morning on their patient. They were going straight to the OR and letting their PA round. And I mean, it was awful. Like I could tell you so many stories, just a quick illustration. One of the surgeons that was practicing when I quit, I didn't quit, but when I quit nursing,
forcefully resigned.
Yes. One of the surgeons walked in a room one day and asked me if the patient was being paced. Like, what? Like, because you put external pacing wires on patients after open heart surgery. And when you look at a heart rhythm on a monitor, if a patient is being V-paced, you can clearly see, like, I could tell somebody who's never worked in healthcare a day in their life, this is a paced rhythm, this is an unpaced rhythm. And you can clearly see it. Like it doesn't, you would know forever.
Right. Yeah. It doesn't.
And he's like, is this patient being paced? Like needed to ask me. And I'm like, this is an issue. Like this is a major problem. And so I think what happens in the hospital stays in the hospital. People think generally all doctors are smart. And I wouldn't say that now. Like people now kind of know. And I'm not saying all doctors aren't smart. Smart and intelligent versus practical application are two different things. And I just think the level of caring has went down so much. The ability to ask questions, pride has gone up exponentially. I think it's just, I don't know, things have really changed.
How did that experience kind of, I don't know where you were at previous, but I know that when you are in conventional schooling or are in a conventional setting, like we are very much taught one kind of modality and one way of thinking. Prior to you forcefully being made to resign, was your brain
has to be successful somewhere else?
Right. Has to go take your talents elsewhere. Was your brain already kind of moving into questioning the medical field, or did you find that occurring once you stopped working at bedside? Is that when you started to kind of change your thought process or look into kind of a different side of medicine?
Yeah, no, I've always been kind of a rebel on that front. And I won't say that I was always questioning medicine exactly, but just questioning things in general. Way back to when I was in nursing school, I was always the nurse that declined the flu shot. And, people were like, oh, why, medical students arguing with me about it as they rolled open heart patients in, like, why would you do that? And like just having these conversations with me, bickering with me online about things. And I've always kind of questioned, and 2020 really opened me up to being able to do it online, or realizing there was a need for it online and in public a bit more. And I'm not I don't want to push my views on people. Like, I don't care what you choose, either one of you. I don't care what you guys choose. I don't care what your listeners choose. Like, that's not my job. My job isn't to tell people, like, this part of medicine is so bad, you should stay out of it. This vaccine is bad, or this drug is bad. That's not my job. Like, I just want people to be more inquisitive, to ask good questions, to understand what they're doing, to understand that there's a lot of value up front in nutrition, just how you take care of your body in general, that's being overlooked, that's pushing people to have to be in the position to be in the ICU and be taken care of by someone like me in the first place.
Right. The whole point of what I put into the words as medical freedom, part of that is the understanding, the knowledge, the education that we often do not give patients. We are not, not me specifically, but other NPs or doctors, physicians, whoever, when patients go to see them, it's just done, 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 done. Things are just done. And it's not explained, or it's not educated to the patient why certain things are happening, what you're going to take, what you're or not going to take, because this is your decision. I think that is so lost for you and your experience and background as a nurse. What do you think about medical freedom? What do you think, kind of where do you stand with it now, especially now, in 2025? What's your definition of that?
Well, I think the definition of medical freedom has really been hijacked to mean something that is not freedom necessarily. I'll give you an example. I can't remember what state it was. I think it wasn't Utah. It was somewhere out west, but there was a law passed after the COVID vaccine was enacted in a conservative state, or not passed, I'm sorry, a law put forward to potentially be passed to criminalize giving the COVID vaccine. And I put it online. Yeah. So I put it online to my followers and asked what they thought about this.
Do you think Idaho, that this? I believe.
Yes. Okay. Yeah. Okay. You are right. I don't know why I have trouble remembering that, but it's a story that keeps coming back to me. I need to get that down. But I put it out to my followers. Like, what do you think about this? Is it good? Is it bad? Are you unsure? And by and large, people thought it was a really good thing for nurses and doctors who gave the COVID vaccine to be given a felony. And I'm like, that's not medical freedom. This vaccine, whether we think it is good or bad, is currently on the market. If it is bad and harmful to people, it should be pulled off the market, not criminalize giving it, because people can be informed. They can make their own decision. If somebody walks into an office and asks for this vaccine, not being mandated to take it. I'm not talking about mandates here. I think that is absolutely wrong, obviously. But it was being criminalized to give this. And so I think medical freedom is actually having the freedom to be informed with good information, full information. And, yes, and make the choice. And truly, information is never going to be fully without bias, I don't think. I think that's going to be we're going to be really hard pressed to find that. There's always going to be somebody marketing to you and coming at things with their perspective. That's why we have to take on the responsibility as consumers to discern and find the people we trust to listen to and make those decisions ourselves. That's medical freedom.
Yeah. No, I completely agree. And it's also, I think a big part of that too is not feeling bullied. You were bullied. You were bullied into getting the vaccine at the time and then potentially let go. We won't make assumptions, but potentially let go for not wanting to do that. And that to me is a huge part of it, is not feeling bullied. Like, this, what happened to my body, my choice. You know, it makes like it's one way and then not the other. Yeah. If I don't want to inject myself with something, that is my choice, and that should not impact. I should not get bullied for it. I should not get judged for it. That is, it's like being gluten-free or not. You know, this is a medical decision that I want to make or not. And I feel for you, because something, I mean, I'm so thankful for it now, but the reason I had my daughter, my third child, at home was because it was 2021, and I went to a midwife, who midwives historically are, you know, a little bit more holistic minded. And it was a midwifery practice. And the first thing she said to me, I'm like 8 weeks pregnant. This is, I mean, early 2021. The vaccine had just come out. And she's like, so have you gotten it yet? And I said, no. And she said, well, why? I said, because there's zero studies in pregnant women, and I'm 8 weeks pregnant. So my comfort level is not there. There's no proof. There's no efficacy. There's no long-term effects. And I'm saying this to her as another practitioner. And she goes, oh, well, maybe you'll just be more comfortable with it by the end of your pregnancy then. So 6 months worth, 6 months down the line, I'm going to be more comfortable with it because now there's 6 months worth of information that tells me nothing about 5 years in the future.
Well, and like making you more comfortable, like she's worried about you being comfortable with it, not worried about the information being
not the
there.
Actual research or the time needed to collect data, right? That now we're seeing fast forward years later. But it's just like, if I wasn't so confident in that moment, or a practitioner, then I would have felt like this fear-mongering bullying of, oh gosh, okay, to protect myself and my baby, I need to go get this now, even though there's zero information about it in pregnant women. Zero. Like that's bullying. And so that, in terms of medical freedom, is a huge aspect to me.
I have a question.
I knew you did. I could feel it.
So I found out in a roundabout way, because through testing and other blood work that I've done in my blood disorder, that my D-dimer is high, so I should not be doing vaccines. Right. Okay, so I found that out. Yeah, I found that. I went around my hand to get to my thumb to find that out. If you do not have a chronic illness, if you do not have a known blood disorder from other things, how do you find out if your D-dimer is high or if you should not be taking vaccines? Like, I haven't had the flu shot. I mean, I got my vaccines when I was a little kid, because that was back in the 80s and 90s, and you don't know what you don't know, right? But I could have died as a little kid because they never tested or told my mom that I had a high D-dimer when I was a little kid and had blood work done.
Yeah. I mean,
so how do you do that now?
I have a question for you, Anna Kate. So with your D-dimer being high, have you actually been, like, did you figure that out on your own, that it would be dangerous for you to take something like the COVID vaccine? Or did a provider tell you, like a traditional, Western medical provider, say, this would be dangerous for you? Because I don't think anyone at my hospital would have put that together. So I'm just, okay.
She told me.
Okay. Yeah.
I mean, so this was 2000.
Like, listening to this, I feel like people would think, oh, maybe like a doctor told you that's bad. And like across the board, anybody with a high D-dimer wouldn't be told that it's bad. And I don't think that's the case.
No, absolutely not. It's definitely not the case. Yeah. I mean, at least I have never come across a conventional, I don't want to say never, but I cannot recall any conventional doctor that I've come across that will halt a vaccine for any reason. I mean, even in pediatrics, when I was doing my rotation at a very conventional pediatric practice down in Florida, even if the kids were febrile and sick, back in the day, we quote weren't supposed to give vaccines when the kid is sick. No, it's fine. They can have it. I mean, there is never a time where I have clinically seen, if I was in a conventional setting or speaking to a conventional doctor, where they would not give one.
Yeah. Which in and of itself should be super telling, because if generally across the board the practice is there's never a reason not to give a vaccine, when we know with other medications, blood products, anything, there are reasons not to give, that's very strange. And that alone should cause people to ask a lot of questions.
Yeah, no, I completely agree. And I think, AK, your question, that's the biggest problem, is that it's not one size fits all, and we make it the system and the schedule makes it a one size fits all solution for every single child in this country, and even every adult, in terms of Tdap boosters or the flu shot or the COVID vaccine. And we are all so incredibly different that it would be, we talked about this before, it's a matter of, okay, there's adverse effects and side effects of medications. There's adverse effects of freaking vitamin D. If you take too much vitamin D, it can be neurotoxic. Same thing with vaccines. Like, why are we so blind that vaccines could potentially trigger people in different ways when a medication could do that and we know that, or when a supplement could do that and we know that? It's like this whole taboo just subject that in history has been greatly covered up, that people can possibly react to something different, like you with your D-dimer.
Absolutely.
It blows my mind, because my mom was trusting that I was okay to be able to do all this stuff.
Yeah.
I mean, the same thing, like along the same lines of like methylation, like there's a test for that. You can see if you like there's a test. But so how do we I don't think it's possible. How do we communicate to you listening at home, hey, there are things, if you don't know this about yourself, next time you do a blood test, have them, because they can run your D-dimer, right?
Very easily. Yeah.
And that may not be that may not be the trigger, that may not be a thing, but especially for little kids, because that's dangerous. And then with all of the COVID vaccines, and then people were having heart issues and like all of that. So I want to avoid
the issue is it's so multifaceted. Is like, I'm not going to say that, okay, a D-dimer could be negative, but I could still have a child have an adverse reaction to a vaccine because of the adjuncts. So it's like, you can't test.
There's too
many variables that you could possibly react to. Yours is D-dimer. Most other people have normal D-dimers. Okay. So I'm not concerned about that, but there's 15 other ingredients in this vaccination. We might not be reacting to the deactivated pathogen. You might be reactivated to the deactivated pathogen, or you could be reacting to one of the 15 added ingredients. And that's where it becomes an issue. Like, yes, there's methylation testing. Yes, there's genetic testing. Yes, there's, micronutrient defect, testing. And you can kind of like set kids up for success by building the groundwork and their gut work and their mitochondrial function. But you cannot, it's Russian roulette.
Yeah.
You cannot possibly, with 100% certainty, say that this child is not going to react when there's too many variables within that one, and then 5 are given at the same time.
Yeah. And that's sad.
So, okay, deep dive question for you is, if you had to, what's the number one thing that you, looking back at schooling, that you had to kind of unlearn from nursing school? Is there anything that kind of stuck, that was ingrained in your system from school, that you've had to work to kind of unlearn?
Okay, I know that most people are going to think I'm going to say something along the lines of pharmacology or indoctrination, but, well, I guess this is kind of indoctrination, but I'm going to go with the climbing the ladder mindset, the mindset of like women needing to climb this ladder, because I did go to a 4-year university. I went to Purdue, and before I ever graduated, before I ever, set foot in the hospital at the bedside with my first nursing shift, I was already being told, what we need to do, what we need to think about to further our education, to go on and get my NP, to go on and get my doctorate, to go on to CRNA school. And I actually stumbled into CVICU. I'd originally wanted to be a flight nurse. And so I stumbled into CVICU. I won't go into that story, but fell in love with hemodynamics and was like, I really think that being a CRNA would be great for me. But I wanted to do it mainly because of the money. Let's be honest. The money for being a nurse anesthetist is really good.
Yeah.
So I was like, but it's like 3 years of school. And at the time I was like 24, 25 when I was thinking about this. I was like, oh, by the time I graduate, I'll be 28. I'll be having to get my feet wet. And then I'll be like pushing 30 by the time I want to have kids, because I didn't want to be having kids while I was in school, wouldn't be able to spend time with them. And by the grace of God, I went against my nature and decided not to go to CRNA school and chose the family and kids. And I'm so thankful for that, because we didn't have all this online conversation at that time in 2006 to 2008 about moms having value in the home. And it was very much the climb the ladder mindset, make other people impressed with your credentials. And so that's the biggest thing. I think I know there is a lot of indoctrination in school, but I wasn't as affected by that. I was mostly not infected. It's a Freudian slip. Affected by the indoctrination of climb the ladder, be successful, be someone that other people can be impressed with.
I love that.
I have a question before we move on. What is CVICU? What does that stand for? For those of us that are not in...
You made it this whole conversation.
Well, I've been waiting for the right time. I should have asked it at the beginning.
I'm sorry. So it's cardio...
Someone else is...
Yeah, it's cardiovascular ICU. It's some places just call it cardiac ICU, but cardiovascular ICU is what we called it. We took... Primarily, our patient set was people who had massive heart attacks, needed open heart surgery. We recovered the open heart surgery, lung disease issues, ran ECMO, did like continuous renal replacement therapy, like continuous dialysis, those kind of things on patients, vascular issues like leg vascular issues. But we also took overflow from critical care. So we did get a lot of the COVID patients, any COVID patient who needed ECMO, those kind of things we got. So that was our primary. And we got some traumas. It was overflow as well. So, but no pediatrics. I didn't do peds, and I'm thankful for that. I don't think my heart could handle that.
Yeah, peds is it's a hard place to be. That's for sure.
So join us next week as we continue our conversation with Rita Rogers. We're exposed to more toxins than we realize, from food we eat to products we trust. But what's really in these everyday items, and how can we reduce our exposure? In today's Toxin Tamer, we're breaking down fluoroquinolones.
Yeah, she nailed it. Usually I give her the hard words. All right, so fluoroquinolones are a class of synthetic broad-spectrum antibiotics. That means we can use them for a wide array of information, but they are designed to treat a lot of bacterial infections. They are part of the quinolone family of antibiotics that are highly effective for both gram-positive and gram-negative bacteria, which makes them very useful when you have infections, maybe you don't know what they are, or if they're very severe infections, including respiratory infections, urinary tract infections, GI, and skin issues. Yes, ma'am, she has a question.
What's gram-negative and gram-positive? Can you explain that?
No, I don't want to explain. Okay, so bacteria, basically, if we're gram-positive or gram-negative, it indicates where the bacteria can live and survive and thrive within your body and how they are shaped. Is that enough for you?
No. I still don't understand. Okay, explain it to me like I'm an 8-year-old.
Okay, so basically if we have gram-positive versus gram-negative, gram-positive can be attracted to certain types of information, like certain proteins. Gram-negative are opposite of that. They're attracted to the opposite type of information. So it's
like two sides of a magnet.
Two sides of a magnet.
They're okay, yes. That makes more sense.
Two sides of a magnet. And it also can indicate if they can survive in oxygen or not. So if they're anaerobic versus aerobic, it depends if they survive with the oxygen or without oxygen, i.e. in the bloodstream or outside of the bloodstream.
Yay!
So when we talk about different gram-positive, gram-negative, it has to do with their shape. It has to do kind of with their polarity, what they're attracted to, and their ability to either survive in oxygen or not.
Okay. If you were today years old when you learned about gram-positive and gram-negative and learned something new today, let us know in the comments. Because
like back to high school biology.
Yeah. I didn't learn that in biology.
Maybe not. Maybe that was college.
Maybe. But
we're going on.
I learned something. So there's all of this jargon and all of these words, and until we can break them down and understand them, because you talk really fast and you say all these big words and all of these things, and especially as a patient, like you're going through, and it makes sense in your brain of how all of these things work together and the cascade of what's going to happen, but I don't know that. So this helps me understand kind of what the purpose of these synthetic antibiotics and what they're after and why one is going to work over the other.
When you have a class of antibiotics, usually they work for one. So usually they work for just gram-positive or just gram-negative bacteria. When you have a broad spectrum, that means it can kill everything.
Okay.
That's why it's broad spectrum instead of very specific. So some of these really common fluoroquinolones are Cipro, Levaquin, Avlox, ofloxacin, and Factive or gemafloxacin. So they're all the fluoxacins is how you can remember them. Even if you don't remember the brand name or the generic name, fluoxacin is always going to be the ending
of
fluoroquinolones. But essentially they work by interfering with the bacterial DNA replication process of that bacteria. So it prevents that bacteria from multiplying and spreading, which allows the immune system, of course, to then fight the infection more effectively. They are very effective antibiotics. They are highly effective because they treat a wide range of bacteria. So again, if you're in an urgent situation where maybe nobody knows what's going on, whether it is gram-positive or gram-negative, we can give a fluoroquinolone to help eradicate that.
Okay.
So that's a key reason why they're widely used in clinical medicine. However, their effectiveness does vary depending on the type of infection and the resistance against the bacteria. So this is really important to know. When we talk about resistance versus sensitivity, if you have an antibiotic resistance, it means that if I give you, and let's say you have one to fluoroquinolones, if I give you a fluoroquinolone, yes, you are punching it in the face.
I'm gonna put up a fight.
Yes, you are. You're not going to be receptive to it.
Viva la resistance! That was really bad French.
It ain't going to work for you.
Yeah.
If you are sensitive to it, it means it is going to work for you. It's going to come in and be able to knock down that bacteria that we're getting. So that's just important to differentiate when we talk about things like antibiotic resistance. Fluoroquinolones, we can use them again for respiratory infections. So such as community-acquired pneumonia, COPD-related exacerbations. They're highly effective for patients who have strep pneumonia or HIV, Haemophilus influenzae. Levofloxacin, for example, it has a cure rate of 80 to 90% of those type of infections.
That's awesome.
Yeah, it's really good. We'll get to the not so great part. In drug-resistant strains, however, because of the overuse of a lot of antibiotics, especially fluoroquinolones, sometimes they're only as effective as 10 to 20% in certain populations, especially within hospitals. So that just depends on the bacteria, the age of the patient, the comorbidities of the patient, and what they've been exposed to or not, if they're resistant. UTIs, 70 to 90% of UTIs they can kill, such as E. coli or Klebsiella species, whether you have kidney infections from having UTIs. And then GI, if you have anything like traveler's diarrhea caused by Salmonella or Shigella or Campylobacter species, 90% of these can be eradicated with fluoroquinolones. They just come in there and knock everybody out.
Nice.
Get them out of there. Skin and soft tissue infections is the next one. So a lot of orthopedic doctors will use these antibiotics because they are widely considered. Sometimes I will say in terms of second-line antibiotic, in terms of penicillins and cephalosporins for things like MRSA or SSA infections, because there's a fluctuation rate of about 20 to 40% there. MRSA is an issue anyways. It's literally saying that's resistant. Mm-hmm. So you're going to have a lower effective rate there. Bone and joint infections is another one. Ciprofloxacin and levofloxacin have clinical success rates about 70 to 80% for treating bone and joint infections, especially in other patients that are using corticosteroids as well. Septic arthritis is there.
Oh,
yeah, I know.
That's not.
Yeah,
so arthritis is not fun, but septic does not sound like it's an invitation to a better party.
Yes. So I mean, the rates are there. It is a very, very effective antibiotic. It's utilized for and can be life-saving, let me say, in certain situations. But one of the challenges is the resistance. So we are constantly overusing antibiotics in our country
fluoroquinolones being broad spectrum, you want to save them for when they really, really, really are needed and life-saving. But unfortunately, we aren't only utilizing them in that situation. And so, for example, something like E. coli, the resistance towards it has reached 30 to 40% in some parts of the world because we're just using it too much. And so there's a growing concern for the resistance, but there's also a growing concern regarding their potentially severe and long-lasting impacts on patients. We are seeing patients who are disabled chronically after taking these antibiotics. So that is why I wanted to start with the effectiveness and what they are and why we utilize them, because it is needed and they are life-saving. But we are finding patients, more and more patients, who are coming out of using a fluoroquinolone disabled.
Yes. So they have a specific purpose and a specific time to be used, but allopathic medicine tends to hand out antibiotics for like candy. I mean, myself going through my Lyme journey, trying to fix a viral infection with antibiotics, which only treat bacteria, blows my mind. I have no idea why that was a thing, but they put me on long-term antibiotics. So it destroyed my gut. I went through so many that I became resistant to, can I say them?
Yeah.
So Doxy, and then Rocephin, and then something else with a C, and something else. So I had to move from taking them orally because they quit working to having a PICC line.
And the issue there is now if AK really needed those antibiotics in the future, she's resistant. She cannot use them. They will not work. And that is the problem. It's two problems. One, it creates a problem for her if she's in a life-threatening situation, where these doctors are going to know maybe that she's resistant to all these things and utilize these antibiotics, and it's not going to work for her. So they have to keep cycling and go to those bigger ones, go to those broad spectrum ones like our fluoroquinolones. But then also it helps to contribute to the creation of superbugs, because now you have these bacteria that are learning and evading and adapting their defense mechanisms based on the resistance of the antibiotics. And that obviously causes a problem, because then we run out of ways to kill them.
Right. So sorry, I'll get off my soapbox of why antibiotics should never be used to treat
viral issues. Yes.
100%.
And I mean, they also should not be utilized unless someone actually has a bacterial infection. And that's where we run into problems, right? The overuse does not come from these life-threatening situations. The overuse comes from people who go to the doctor for ear infections, which are 90% plus viral, and end up walking out of there with an antibiotic prescription. Like, that's where the overuse comes, is the everyday urgent care trips, pediatrician trips, etc. Like, save these antibiotics from when they're really, really, really needed. You will not only be benefiting yourself from decreasing the resistance, but benefiting everybody else by reducing the just freaking superbugs that we're creating.
We're going to have a segment of, is this viral or bacterial?
Right. Yeah. Yeah. Okay.
Okay. Off the soapbox.
We're moving on. Stay tuned to next week, because we're going to talk about where else we can find these fluoroquinolones. It's not just from you guys consuming them, from potentially your doctor prescribing them for you, but there are other places that we can find them, and we're going to dive into the depths of what the adverse effects can be and what we can do to avoid them.
You've heard the claims, but are they fact or fiction? Today, we're busting one of the biggest health myths out there.
Are you going to say it?
Vitamin D deficiency is rare. Just go outside.
Do you think that's true? Do you think vitamin D deficiency is rare?
I think people don't go outside enough.
Okay. So vitamin D deficiency in my world is not rare whatsoever, but we have to define kind of the parameters of what deficiency means.
Is it rampant?
I think so.
Okay.
Yeah, I think most people are vitamin D deficient in terms of what my expectations are for you being efficient. So if you're getting a vitamin D blood draw through LabCorp, the parameters are 30 to 100. That's what's considered normal. If I get a patient who's 30, 31, 32, to me, you are deficient, because we fluctuate. Vitamin D kind of acts as a hormone in the body. And so we fluctuate depending on our exposure to that vitamin. So I don't want somebody just barely scraping by. I personally love 65 to 75, somewhere in there. That means I know if you're dipping or, that you're okay, nice and strong. And especially for something like vitamin D that is so crucial to how we synthesize our hormones like testosterone or our immune system. So I would argue that most people are deficient. And most of my patients that I come across, it is also not something where, unless you are working outside for 12 hours a day in the summer, you are probably not getting enough because our soil's deficient, our food's deficient, our just the nutrient-dense foods that we should have access to is either we don't have access to or they are kind of depleted. So I don't think it is just good enough for in the middle of winter where it's cold and
you're bundled up,
and you don't want to go outside. Most of us are vitamin D deficient. There are a lot of other factors as to why people don't get enough vitamin D. Even in the sun, if we are lathering ourselves up with sunscreen, we don't use sunscreen very rarely we use sunscreen, but it is a protective barrier that is preventing something from entering your skin, right? So that sunshine is being blocked. So even if you are outside all day and you're lathering yourself up with a whole bunch of sunscreen, you're blocking some of that vitamin.
And windows and sunglasses affect your doesn't close your eyes. It covers your eyes, so you're not getting that vitamin D and you're not getting the UVA and UVB rays that help you regulate your circadian rhythm.
Exactly.
If you're looking through a window.
Yes.
Like you may feel like you're getting the sun on your face, but your windows are UV protected.
Right. And that literally stops the synthesis of vitamin D. So your sunglasses, the sunscreen, it stops the synthesis of that vitamin D. Obviously, where we live plays a big part of that too. If you live in northern states or super cloudy climates, like right now, it is just gray. Obviously, some sun can still get through, but it can naturally lead us to be deficient for a good portion of the year, depending on where we live. A lot of people don't talk about this. Skin tone. Skin tone creates a difference and a variation in how we absorb vitamin D. And so that and age also. So darker skin tones require naturally more sun exposure to produce the same amount of vitamin D as someone with lighter skin, which puts certain groups at a higher predisposition or a higher risk of vitamin D deficiency. Similarly with age, as we get older, our bodies become less efficient at producing vitamin D from sunlight. So I think it's so... We make it so just clear cut and dry. Get out of the sun and you'll get enough vitamin D. And there just aren't variables that are talked about that could lead us more deficient. And also the impact of that. Vitamin D, it's not just about your bone health. It is critical, like I said, for immune function. When we have a lower vitamin D and what I consider below that 65 to 75 mark, it puts us at an increased susceptibility for the flu, for colds, for more significant illnesses. Direct correlation between low vitamin D and anxiety and depression. So it helps to actually fuel these neurotransmitters and help maintain our mood, so we are at an increased risk of even things like postpartum depression or just our mood stability. That I don't think is talked about enough in terms of what vitamin D is good for. A lot of people have the immune function part down, but not necessarily that it impacts directly how our neurotransmitters are made. In terms of pregnant women and postpartum women, that's a group that I test vitamin D. I test vitamin D on everybody, but that is one specifically that right away I want to know where those markers are at, because a deficiency during pregnancy puts us at increased risk of gestational diabetes and preeclampsia and low birth weight. And for kiddos, proper bone development and brain growth, it is crucial for. So it is a very easy solution. But clinically, I find that most people are deficient. And my patient population is probably the most aware of micronutrient deficiency. Yeah. So if they're deficient, then kind of your average bear would probably be even more so. In terms of exposure to vitamin D, most of us cannot rely on getting outside enough. Unfortunately, general rule, if your shadow is longer than you are tall, you aren't getting enough vitamin D from the sun, just because of where the sunshine is, how we are absorbing it. Supplementation, because our soil and our food is so depleted, is often necessary. So I'll get that question a lot, like, hey, I have a vitamin D of a 25. Can't I just go outside? Well, sure, if you're spending all day, every day with nothing blocking it, and
if you're working naked outside.
Right. And we can get that up to a 60 real quick. Otherwise, that is usually not the average person. So supplementation is often necessary. The best combo is D3, K2. The K2 helps to absorb that D3 so that your body can utilize it more properly and more efficiently. While I would love for it to be solely based on foods, that can be really hard too, depending on the person's diet, what they have exposure to, and the availability. Wild caught salmon is awesome. Farm fresh eggs, the egg yolk is high in vitamin D. Organ meats, those are the big
why they
three.
call it awful.
Huh?
I don't know why they call organ meats awful. I mean, I know why.
The taste.
No.
Wait, what do you mean?
OFFAL. That's what they're and it's pronounced awful.
Oh.
But they're not AWFUL.
I was like, wait, what do you mean they're not
No, they're
awful?
good. They're good.
It's like, where are you going with this? So yes, that's my 2 cents on vitamin D. I do not think that most people can just, quote, get outside and have it become an efficient number. I will try, if patients are low, I will kind of booster it up for a little bit and then get them to a place where they can maintain that with diet and being outside. But if you are really low to begin with, it can be hard to get that up naturally. If you're in the middle of winter and your diet's not great.
Yep. And I can't go out in the sun.
So she takes D3, K2.
I do. Actually, I take D3 because K2 messes with my
her blood. Yes.
So see, you got to know all of these things. So ask the questions, and make sure, like, okay, real quick before we get off of this subject and go on to our finishing up this episode. What is too much?
Oh, good question. So vitamin D can be toxic at high levels. That it is a vitamin that, again, can act kind of as a steroid or as a hormone in the body. So it can be toxic at high levels. In terms of if I'm quantifying it on blood work, so 100 is the upper limit of what's considered normal. I'm okay around a 105, 110, depending on how that person is metabolizing, utilizing it, breaking it down. I don't like to see it get up into the 120s, 125s. I had a baby whose mom was supplementing with vitamin D, too much vitamin D, and she was having actually neurological shakes that looked like tremors. And we obviously had to put her through a whole bunch of testing. And then I landed on the vitamin D, and mom was giving her like over 1,000 IUs. This was like a 2-month-old. And that was it, because it was becoming toxic to her central nervous system. Yeah. So that is a great question. In terms of quantity of the amount to take, I would say most adults around 5,000 IUs is a fairly safe range. If you're sick, 10 to 15,000 IUs can be normal, but it depends where you're starting at. Yeah. So never tell somebody who has a vitamin D blood level of a 75 to take 10 to 12,000 IUs of vitamin D. It's going to catapult them into that heightened area. But someone who's deficient at a 20, I'm going to overload them with about 10 to 15,000 IUs for the first couple of weeks, and then backtrack them to 5,000 IUs, I think is a pretty good baseline for an adult. Yeah. So kids, depends on the age.
Talk to your medical provider, get your vitamin test done before you overdose or change your supplementation to vitamin D.
Yes.
So, and until next time,
let's discover together.
Feeling a little skeptical? Good. Because today, Rita Rogers just showed us why questioning the status quo isn't just smart, it's essential. From antibiotic risks to vitamin D myths, we've cracked open some huge health misconceptions. But now it's your turn. What is one thing you had to unlearn? Let us know. Share this episode with someone who needs it, and make sure you're subscribed, because we're not done busting myths yet. See you next time. Before diving deeper into the wellness world, let's pause for a quick disclaimer. The information shared on this podcast is for general informational and entertainment purposes only. While we love being your Discovery Doc allies, we're not here to replace your doctor or healthcare provider. Consider us your fellow health explorers, sharing our findings as we uncover the mysteries of well-being. Always consult with a qualified medical professional before taking any action based on the content of this podcast. Just like an archaeological dig, this disclaimer may change occasionally, so be sure to check back for updates. Stay healthy, stay curious, and keep exploring with the Discovery Doc.